Hello everyone. So today we are going to discuss periodontal flap surgery. So this is an important periodontal procedure, and by the end of the lecture you'll understand its definition, indications, techniques and different flap designs. This is Dr. Sugirtha, Reader Periodontics. So according to WHO, by the age of 19, about 2/3 of the world's population will have some form of periodontal disease. By 40, that number jumps to over 90%. Periodontal flap surgery is one of the key ways we can manage these diseases and restore the periodontal health. So 5 mm standard for referral. So in clinical practice, pockets of 5 mm or more are generally considered a standard point for referral for possible flap surgery, especially if they persist after initial therapy. So next is definition. So a periodontal flap is that section of gingiva or mucosa significantly surgically separated from the underlying tissues to provide visibility of and access to the bone and the root surface. The base through which the attachment and circulation is maintained is called a pedicle. So, a periodontal flap is a section of gingiva or mucosa surgically separated from the underlying tissue to give visibility and access to the bone and root surfaces. The part that stays attached and maintains circulation is called the pedicle. Indications. So we use flap surgery to gain access for thorough scaling and root planning and to enable resective or regenerative procedures that reduces pocket depth. So to create accessibility for proper professional scaling and root planning and enabling resective and regenerative procedures and hence reducing the periodontal pocket depth. Contraindication. So it is not done in uncooperative patients, those with uncontrolled systemic diseases, or in patients with recent organ transplants as healing may be compromised. Classification. So classification based on the bone exposure. So by bone exposure we can have a full thickness flap or partial thickness flap. Partial thickness is indicated in resective surgery but avoided if the alveolar bone is thin or if there are dehiscences and fenestrations. Classifications according to the placement of the flap. So the flap can be displaced either coronally, laterally or apically or undisplaced, which improve the access and remove the pocket wall during the initial incision. So these are the difference between a full thickness flap and partial thickness flap. So in a full thickness flap, all the soft tissue is reflected and bone exposed. In a partial thickness flap, epithelium and a layer of connective tissue is exposed. Here it is a primary healing, there it is a secondary healing. Full thickness is technically easy, partial thickness is quite difficult. Full thickness flap, there will be decreased bleeding, but in a partial thickness there will be more bleeding. In a full thickness flap, there is decreased post-operative swelling and pain. In a partial thickness, there is increased post-operative swelling and pain. So in full thickness, widened zone of keratinized gingiva, and here there is no widened zone of keratinized gingiva in a full thickness. Here the widened zone of keratinized gingiva is there. For fenestration and dehiscence, it is no. Dehiscence and fenestrations, yes, we can go for a partial thickness. Nauseous surgery, yes, a full thickness flap can be raised, but nauseous surgery, a partial thickness flap cannot be raised. So next is the classification based on the placement of the flap we have already seen. Coming on to the apically displaced flap. So this involves a reverse bevel incision using a BP blade. The distance of the incision depends on the pocket depth and the gingival width. So the flap is reflected beyond the mucogingival junction. For apical repositioning, tissue collars are removed and bone is recontoured and the flap is sutured. Okay. So you can see here. So reverse bevel incision was placed with the Bard Parker blade number 12 or number 15. The distance of the incision is dependent on the pocket depth and the width of the gingiva. If the gingiva is thin and narrow zone of keratinized tissue is present, then the incision is made closer to the tooth. The beveling should be scalloped to ensure maximum coverage of the alveolar bone. Vertical releasing incisions are made. A full thickness mucoperiosteal flap is elevated using a periosteal elevator. The flap is reflected beyond the mucogingival junction to facilitate the apical repositioning. The marginal collar of the pocket tissue is removed with curettes and exposed root surfaces are plain. The alveolar bone crest is recontoured using surgical burrs. The buccal and the lingual flap is recontoured to the level of alveolar bone crest. The flap is sutured with simple loop interrupted sutures and periodontal dressing is placed. So the advantage of an apically displaced flap is it results in minimal pocket depth post-operatively and minimal post-surgical bone loss. So this is an apically displaced flap. Coming on to the coronally displaced flap. So it was defined by Wenstrom in 1996. Okay, and this flap achieves 70 to 99% root coverage with 2.5 to 3.7 mm clinical attachment gain. It is designed to position the flap coronally to cover the exposed roots. So indications, it is indicated for aesthetic root coverage and sensitivity reduction, but contraindicated when keratinized gingiva is inadequate. So coronally displaced flap, you can see two vertical incisions are placed. Okay, and then it extends beyond the mucogingival junction. It extends beyond the mucogingival junction. The internal bevel incision is given from the gingival margin to the pocket depth. Through thorough scaling and root planning is done. The flap is displaced to a level coronal to the pre-treatment and it is sutured. Semilunar coronally repositioned flap. So it is indicated in small recessions of 2 to 3 mm, no sutures needed and has minimal aesthetic compromise, but it's not suitable for large recessions. So this is the semilunar coronally repositioned flap. So the incisions are made here. So the flap is raised and then it is placed forward and adapted. Next is your laterally repositioned flap. So it is described by Group and Warren in 1956. So it is used for isolated denuded roots with adequate lateral donor tissue. So it involves incising around the exposed root, creating a lateral flap and sliding it over to cover the defect. And it is contraindicated. It's avoided in multiple recessions or when the keratinized gingiva is thin. So a laterally repositioned flap. So first an incision that is resecting the gingival margin around the exposed root is made. Thorough scaling and root planning is done. Wide vertical incision from gingival margin to outline the flap adjacent to the recipient site is made. Then short oblique incision into the alveolar mucosa at the distal corner of the flap is made. Slide flap laterally onto the adjacent root. Fix the flap to adjacent gingiva and alveolar mucosa with interrupted sutures. Coming on to the palatal flaps. Palatal flaps are used to achieve soft tissue closure around implants and to increase keratinized tissue thickness. Classification, depending on the management of papilla, either we can do a conventional papilla preservation of a conventional or a papilla preservation flap. So we can use conventional papilla management or papilla preservation technique depending on the interdental space with an aesthetic needs. So use conventional flap, they are used when interdental spaces are too narrow to preserve the papilla. It involves splitting the papilla and reflecting the flap while keeping it thick. So indications when the internal spaces are too narrow and the flap is to be displaced. And papilla preservation flap by Taki et al. In the year 1985, it is indicated for wide embrasures. It preserves the papilla for better aesthetics. Technically, it is more difficult and it is time consuming, but it prevents the post-op tissue craters. So technique, incise the tissue at the bottom of the pocket and to the crest of the bone, splitting the papilla below the contact point, reflect the flap, maintaining it as thick as possible. So this is a conventional flap procedure. So this is the papilla. See, the incisions are placed on the outline. Individual papillary flaps are reflected. The papilla is pushed buccally through embrasures. Root planing is done. And the flaps are sutured palatally. So advantages are aesthetics, prevention of post-operative tissue craters, and disadvantages, technically difficult and it is time consuming. Next is, so this is, Coming on to the classification, that is pocket therapy. Pocket therapy with flaps can aim at elimination or reduction and both allow for regenerative procedures and better access to deposits. So these are the objectives of flap technique for pocket therapy. Pocket elimination by gingivectomy. So Robizak in the year 1884 and Goldman in the year 1951 discovered gingivectomy. So gingivectomy procedure employed today mainly for pocket elimination and establishment of physiological gingival contours. So these are the steps in gingivectomy. First, the bleeding points are marked. A beveled incision is placed towards the base of the pocket. Remaining tissue is removed. Secondary incisions are made to separate the interproximal tissue. Contours are refined and the dressing is placed for 10 to 14 days. So we can see the step by step. Next, the pocket reduction procedures. So the pocket reduction procedure was given by Leonard Widman in the year 1918. So this involves vertical and gingival incisions to expose the bone, remove the inflamed tissue, perform root planing and recontour bone before suturing. So here the vertical incision are placed from the mid-buccal regions of the peripheral tooth. See, two vertical incisions are placed. These incisions are joined by the gingival incision which separates the pocket epithelium and the inflamed gingiva from the non-inflamed gingiva. So a mucoperiosteal flap is elevated to expose 2 to 3 mm of the bone and the collar of the inflamed tissue around the neck was removed with curettes and exposed root surfaces were scaled. Bone contouring was recommended. So the flap margins were placed at the level of the bone crust and secured with simple loop interrupted sutures. So the advantages are less discomfort to the patient and re-establishment of proper contour of alveolar bone in angular bony defects. So next is the Newman flap in the year 1920. So here it uses clavicular and sectional releasing incisions to access the root surfaces followed by curettage and suturing. So clavicular incisions are placed followed by sectional releasing incision. So next comes your Kirkland flap in the year 1931. So this involves intraclavicular incisions and careful debridement without extensive tissue sacrifice, allowing easier apical displacement. You can see here, it is intraclavicular incisions are made on the buccal and the lingual aspects of the ingenital area, which was extended into the mesial and distal direction. The gingiva was retracted labially and lingually, which was carefully debrided. So the advantages are extensive sacrifice of tissue is avoided, apical displacement of flap is facilitated. Modified Widman flap by Ramsford and Nizzle in the year 1974. So this aims for close soft tissue adaptation to the root surface with minimal trauma. It involves precise initial incisions, flap elevation, removal of inflamed tissue collars and suturing without major bone exposure. See, the advantages are possibility of obtaining a close adaptation of the soft tissue to the root surface, minimal trauma to the soft connective tissue, and less exposure of the root surface, enabling the treatment in the anterior segment. Disadvantages: unfavorable interproximal architecture immediately after the removal of surgical dressing, and it does not reduce the pocket depth. So these are the steps in modified Widman flap. So initial parallel incisions are made closer to the gingival margin. The flaps are elevated minimally. Parallel incisions are made and then flaps are elevated. A third incision removes the gingival collar and tissue tags are removed before adapting and suturing the flap. So tissue tags and granulation tissues are removed. Bone architecture is not corrected except if it prevents good tissue adaptation to the necks of the teeth. Flap is adapted to the buccal and lingual walls and suture. See, we have given an internal bevel incision and then debridement and suturing. So, periodontal flaps are versatile tools for pocket elimination, access, regeneration, and aesthetic correction. The choice of the flap depends on anatomy, defect type, and treatment goals. So, thank you for listening.